folks are still signing on, which is great. I wanted to introduce our next speaker, which is Dr. Helen Lawler, who's associate professor in the Department of Medicine, and she's one of our colleagues in the Division of Endocrinology. She's also the medical director of the Diabetes Home and Remote Program. She went to college at UNC Chapel Hill and med school at Virginia Commonwealth University and did residency with me in internal medicine here at the University of Colorado, and then did fellowship in endocrinology also at University of Colorado. So she's speaking with us this morning about CGMs and how to think about using those appropriately. I'm really looking forward to this talk. So Dr. Lawler, thank you for joining us and being so patient with us.
Well, thanks for having me. I'm sure you're almost having a heart attack that I wasn't coming and forgot or something, but I didn't. Like I said, I was there and it's empty, and I was like, oh no. So anyway, I'm here. Luckily, I have my computer with the presentation. So I will share my screen, and I hope everybody is staying warm in this very cold weather. I was in Canada over the weekend and came back last night, and it's colder here than it was in Canada, actually. There's a hockey tournament there for my kiddo. All right, let's see, sharing screen, and then let's put this on here, presentation mode. All right, can you see that?
Yep, that's coming across.
Perfect. All right, so again, thanks for having me. I'm looking forward to talking about how we use CGMs in managing type 2 diabetes. So the objectives today is we're going to go over the benefits of using CGM for managing type 2 diabetes. I'll provide an overview of all the different brands and types of CGMs that you can use with your patients. And then I'll go through how to analyze the reports that we get for the CGM and the metrics that we see in this AGP report, which stands for ambulatory glucose profile that is provided per CGM. And then we'll go through some case studies. I have 3 examples and maybe a 4th as well to show you on how we interpret those reports. And then also I'll let you know who are good candidates for the CGM, how we use this technology in our clinic, and how we bill for CGM as well. So benefits, the A1C reduction with CGM use is beneficial just with CGM use alone, not even with changes in medications. So this was a publication done by numerous diabetologists across the country, from Washington State all the way over to Atlanta, Georgia. So a group of diabetes specialists came together and published a publication indicating that CGM should be available from insurance companies for all type 2 diabetics, even if they're not on intensive insulin management. And the reason why they're advocating for insurance to cover this is because of all these studies, numerous studies, randomized as well as retrospective and prospective trials, have shown that CGM use is beneficial to patients with type 2 diabetes. And you can see here the first trial by Aronson. In that trial, they actually looked at patients who were not on insulin therapy with type 2 diabetes, and they actually had A1C reduction and a change of CGM metrics. They looked at both of those in the study. So the X over there means that, yes, it was beneficial. Those outcomes were looked at, and there was a change in A1C. In that particular study, the A1C reduction was about 0.3% reduction in A1C with just CGM use alone. And all of these trials, it usually ranged from about 0.3 to around 1% A1C reduction using CGM in patients with type 2 diabetes. In addition, the safety benefits of CGM use are huge, especially patients who have hypoglycemia unawareness or brittle diabetes with recurrent hyper and hypoglycemia. The arrows are very helpful for the patients, indicating when their blood sugar is rising or falling rapidly, so they can treat before they get in harm's way. In addition, the alerts are very helpful, the low blood sugar and high blood sugar alerts, especially patients who might have inability to control their diabetes all on their own. You can share this data with a significant other or family member or caregiver who can also receive these alerts and data on their phone as well. And then as we'll see here when we go through some of these case studies, it's very helpful for us as providers to see CGM patterns and make changes to their diabetes medications. Unlike when people are doing finger sticks, where they usually just check right in the morning, and oftentimes those blood sugars are okay, you can see postprandial patterns where often people are having postprandial hyperglycemia, and then you can adjust insulin accordingly when you see that pattern, or add, a GLP-1 agonist or SGLT2 inhibitor, which can target that postprandial hyperglycemia that patients are having. Patients also like seeing the patterns where they get constant feedback that if they eat a bowl of pasta, their blood sugar might go up to 300s, and then it might discourage them from doing that again. So the patterns are also very helpful to the patients as well to see what foods do to their blood sugars. And then a lot of patients, a burden for them having better diabetic control is the constant finger sticks, and they hate doing it and they won't do it. And I'm sure you have a lot of patients who are like this, and the CGM provides a tool for them where they can wear it for 10 to 15 days and see constant blood sugars without always having to poke their fingers, which the patients are very appreciative of. And we can get better control that way as well, having that data that you wouldn't have otherwise. And then also there's a lot of patients out there where the A1C is just not accurate, where it's falsely high or falsely low. And the CGM provides the average blood sugar over that time period, and the GMI, which we'll talk about, which is a great A1C equivalent for patients whose A1C is not reliable, such as those with renal failure, sickle cell trait, different types of anemia that are being treated, untreated, and things like that. So here is a list of our continuous glucose monitors, and I highlighted the CGMs that we use most often. So Dexcom and Libra by far are the most popular choices in our clinic patients, and I'm sure in the patients that you have on CGM as well. And I listed all the different types and brands and models out there, and I'll go through that with you as well, because it's a little complicated of what the companies are doing in the future with especially Libra. Then other options for patients is Guardian, the Guardian sensor. And I put a picture here on the left. You can see what the size and shape of the Guardian sensor looks like. This is Medtronic's product. I personally, and I would say the majority of us in clinic, don't have anyone using this on an individual solo basis without it being attached to a Medtronic pump. But it is an option for patients who are interested, and it does communicate with an InPen, which I'll go through with you later as well. And then here on the right, I showed a picture of the Eversense 365. So on the left of this right picture, let me see if I have an arrow. Well, maybe, I don't know if you can see my arrow or not, but you can see this little sensor with the little blue things coming out. That is inserted subcutaneously in the skin by an endocrinologist, and then that stays there for a complete year. So the sensor's buried underneath the skin, but then they still have to wear the transmitter, that little black oval there. They have to wear the transmitter on top of their skin still. And then you also still have to calibrate the Eversense once a week with finger sticks, where the other CGMs like Libra and Dexcom, you don't need to calibrate those. So Eversense is an option for someone who's interested. We currently do not have any providers in our clinic who do it. Maybe when the product's a little more sophisticated, we don't have a lot of takers for having it inserted and then also still having to wear that external transmitter. But Richard Milstein, who is an endocrinologist that did his training with us, who's in Greeley, he does know how to insert the Eversense and has been doing that for the few patients who want it. So that's a good option if you have a patient who's interested in the Eversense CGM. And then there's two over-the-counter CGMs that have come about over the past year, Lingo and Stello. And so I'll go through those on a separate slide, some more detail on those. So this is the Libra 2 CGM, which is an older model, not quite as accurate as the newer Libras that have come out. And they're actually going to phase out production where this will no longer be available come the summer in August. So we personally don't have a ton of patients that are still using this product, but I do have a handful that haven't converted over I'm not sure why they haven't, but they didn't want to. But it has to be scanned every 8 hours to record data. Otherwise, it won't record data. And that could be a barrier to this CGM because oftentimes patients aren't scanning them. So the company is advising that patients replace this one with the Libra 3 Plus or Libra 2 Plus, which are the newer models of Libra coming out. So here's the Libra 3 CGM, which we see a bunch of patients in clinic on this at the moment. Their big selling point is how small it is. It's the size of 2 stacked pennies on top of each other that patients can wear. They can put it, I know the FDA always says, you know, oh, it's only approved on the arm, or oh, it's only approved on the abdomen. So sometimes people see that in the insert and they'll only wear it on the arm. But it can also be worn on the abdomen as well. And so I tell that to some patients who aren't enjoying wearing it on the arm because it's getting caught on their shirt and things like that. So they can wear it in either place. This one is a 14-day wear, and you only scan it once. You can use your phone to scan it, or patients can be given a reader to scan it one time, and then it'll constantly read the data for 14 days before it needs to be changed. It collects data every minute, is its algorithm, and it obviously has the high and low alerts and the trend arrows, and you can share the data on your, if it's on your phone, you can share the data with a caregiver who also needs or wants to see your blood sugars. And then in clinic, we use the LibraView portal to view the patient information, but this too is going to be discontinued in the fall, in September. They're going to stop making the Libra 3 and are advising that patients replace this with Libra 3 Plus or Libra 2 Plus. And we just caught wind of this literally last week that they're phasing this out. So they're going to replace it with Libra 2 Plus or 3 Plus. And the biggest difference is this is a 15-day wear instead of a 14-day wear. Still very small. But you can see here on this chart, I put that the Libra 3 Plus has a better Bluetooth range. It can be read up to 33 feet, unlike 20 feet with the other, the Libra 2 Plus product. So, I mean, if either are available, I would choose the Libra 3 Plus for your patients. These Plus models are also compatible with our insulin pumps, which we also call these automated insulin delivery systems. And I'm going to show you some of those on the next slide as well. And patients can wear the Plus solo, though. It doesn't have to be attached to a pump or syncing with an insulin pump. Again, a reader will work with these products if patients want to use a reader instead of a phone. We personally enjoy it when people use their phone because then we can sync them to our portal in clinic, where the reader you have to download manually in clinic. But there's some patients who prefer using the reader. And so then Dexcom, which is the other major competitor to Libra that a lot of patients are wearing, is Dexcom G6 and G7. G7 is their newest product. And so I put pictures down here what the G6 sensor looks like on the left, and then the G7 sensor on the right. Both of these are a 10-day wear. Again, they can use a receiver or a smartphone to see their data. There's 2 apps that patients can download on their phone. There's Dexcom, where they can constantly see their sugar. That's the platform that shows their blood sugar. And then Clarity can help them analyze their data, which is similar to the reports that we see, the AGP reports as well. The patients have access to Clarity as well. No scannings involved. There's no initial scan. It just starts reading upon insertion, and it reads the blood sugar every 5 minutes. Also high and low alerts, trend alerts, can share with caregivers, and these 2 are compatible with insulin pumps, and we view their data in clinic on the Dexcom Clarity app. The biggest difference between these 2 is G6, the transmitter is reusable, where patients need to use it for 6 months and then they're given a new transmitter. So they have to hold on to that transmitter. It's not disposable. Whereas G7, the transmitter and the sensor are all combined in one, just like the Libra is. And so it gets tossed after 10 days. The whole thing just gets thrown away. And it's a combination. The other biggest difference is that G7, it warms up in 30 minutes. So patients can start seeing their blood sugar in 30 minutes, where with G6, it can be up to a 2-hour wait time until the data starts being displayed for them to use. So patients are really liking the 30-minute window. In comparison, Libra is a 1-hour warm-up time. And when it comes to comparison of Dexcom versus Libra, they're both pretty similar when it comes to accuracy. They say Libra, when you look at the MARD, that Libra is just slightly more accurate, but nothing that would really affect our clinical decision making. So they're both great products. So here are the insulin pumps that we currently are using. All of them are these hybrid closed loops, meaning that it uses the CGM data to constantly adjust the basal rate of insulin. And as I mentioned, Medtronic is the only pump that does not use Dexcom and or Libra, where they use their own sensor. So they have the Guardian 4 sensor is needed for this closed loop to work with the Medtronic. The latest model is the MiniMed 780G, and this has been a really good product. Unfortunately, some of their prior models weren't as great, and a lot of patients jumped ship from Medtronic over to Tandem and other insulin pumps because mainly it was the sensor that wasn't so great on their prior models. Omnipod is the only insulin pump that we have on the market today that is tubeless. So you can see here the reservoir that patients wear on their, they can wear it on their abdomen, they can wear it on their arm, and that stores insulin where they can change that out every 2 to 3 days. And a lot of patients who are active, I have some plumbers and things like that, that they really enjoy wearing Omnipod 5 because of the tubing that won't, in lack of tubing, so it won't get caught on anything. And it can communicate with Dexcom or Libra. For all of these, now that Libra is starting to integrate, I would have to say Dexcom has been the initial CGM to integrate with the pumps. And so we really have not converted a lot of people over to Libra with the pumps because we really don't have good clinical data of how that's going to go. So most patients are using Dexcom, but Libra just recently has been integrated with these pumps. So here's Tandem. The Tandem products are the T-Slim, and then Mobi is their latest addition. I think they came out with Mobi to compete with Omnipod because it's small. As you can see, they're comparing it to the size of a quarter, and you can use this adhesive tape to tape it on your skin. So it's kind of like an Omnipod, but it still has tubing where patients can opt for a very small tube at the insertion site or a longer tube like a traditional pump would be. And the benefit of the Tandem is, unlike Medtronic, is their software and the upgrades, patients just plug it into their computer, so they don't have to be sent new devices all the time, where Medtronic in the past, they kept having to be sent a new complete pump every time there's an upgrade. So that has been a nice thing for patients to not have to get new pumps and just upgrade the software. And then the newest one on the market is this iLet Bionic Pancreas. This one's pretty cool in that it's the only one where you don't have to carb count and enter carbohydrates into the pump. Patients just enter regular meal, large meal, or small meal, basically, based on the amount of carbs, but they don't carb count. So it's very interesting. It's a big learning curve for patients and for us as providers because we don't have a lot of tools to adjust the pump. The only thing that we can adjust is the target. So it's a regular target, a higher than usual target, or a lower than usual target. But otherwise, the pump kind of learns how much to give with meals. It takes a special patient to be on this pump because they have to really trust the pump and not try to override it or do fake carbs in there because then it'll really cause problems with the pump. So we have some patients on this, not a ton, but it is pretty neat technology. And it too works with Dexcom and the Libra CGM as well. So here are the over-the-counter continuous glucose monitors. So Dexcom, their product is Stelo, and then Abbott, who makes Libra, their product is Lingo. So with these, they're really targeting patients who do not have diabetes or have prediabetes or diabetes not on insulin. So these both companies say they're not meant for a diabetic on insulin. And the reason for that is there's no alarms and there's no share options. So it's not a really great safety tool, but perhaps very good for the diabetic who wants to know how their blood sugar is doing, who can't get approval from their insurance company for one because they tried to make it cost friendly if insurance doesn't cover their CGM. So it's about $90 to $100 per month for the supply for either of these. The biggest difference is the Lingo product is a 14-day wear. The Stelo product is a 15-day wear, but the Lingo product reads the blood sugar every minute, where Stelo reads it every 15 minutes, which honestly is not a big deal in this group that they're targeting of a healthy, well individual that wants to see how diet and exercise affect their blood sugars. There seems to be a big demand for this of people who do not have diabetes want to see their trends as well. So these are options for your patients that, have prediabetes or diabetes not on insulin who want to pay out of pocket. I do think, though, that if you want to write a prescription, they could still get it cheaper with a prescription for Libra. Libra is about, with a GoodRx coupon, $75 to $85 for a month supply out of pocket. So it's still cheaper than lingo and also has alarms and things for your patients with diabetes that want one that the insurance is turning it down. And then we also have some professional CGMs in our clinic where we can loan these out to patients to wear, and then they come back to our clinic, we download it and analyze the patterns and make adjustments to their insulin as well. So we use the Dexcom G6 Pro and the Abbott Flash Libra Pro as well as a loaner CGM for patients who can't get one or don't want one at home, but for us to help make adjustments to their medications. All right, so how do we analyze the ambulatory glucose profile report? So first, I will just show you what you see in a report, and I'm sure you all are familiar with this. And on the left here, you can see that we get these the graph of how the time in range and above range and below range. So I'll go into that in more detail on another slide. And then you see the glucose metrics where it gives you the average glucose. It usually defaults to 14 days, but as you know, you can pick 7 days, 14 days, 30 days, 90 days, or you can enter your own time range that you want to see their data. So it'll give you the average in this GMI. That's the glucose management indicator is what that stands for. It's basically an equivalent of an A1C. It takes the blood sugar over that whole time period, the average, and then converts it to A1C equivalent percentage. So like I said, that GMI is extremely helpful in patients whose A1C is not reliable. And I have a lot of patients doing telehealth where really the only lab I need is an A1C, and I do not have them go in and get a separate A1C. If I just use the GMI to see how they're doing and this time and range to make adjustments, as this report is way more helpful than just a solo A1C. Then there's the coefficient of variation. So that tells you how much their blood sugars are fluctuating. It takes the standard deviation of the blood sugars over the time period and then divides it over the mean blood sugar over the time period. And then they make it into a percentile. So the lower the coefficient of variation, the lower fluctuation we're seeing. And so we try to keep that number under 36% fluctuation in sugars. And then it tells you the time, how often they're wearing the CGM. And this person is pretty compliant, wearing it, about 97% of the time. And then on your report, you're also going to see these median. You can see here on the top, the graph, it takes the whole time period. Let's say you're looking at 14 days and sticks it on one day with the median. So you can see a trend of how they're doing. And then you also on the bottom here get a day-to-day profile and tiny little display of that as well, that you can go through individual and look at the day-to-day too. So that's how the profile's laid out. And then this is how we target this time and range. So first, when I'm looking at the report, I look at their metrics, their average, their GMI and things like that. But then I really spend a long time looking here at their time and range. So for a person with type 2 diabetes that isn't elderly or high risk, we usually aim for the blood sugar to be between 70 and 180, about 70% of the time or higher. And if this is the case, that usually equates to a GMI of about 7. If they're at about 70%, that usually equates to about a 7 GMI. And then we like to keep the low blood sugars low, under 5% total, with that very low blood sugar under 54, less than 1% of the time. And then we try to minimize the hyperglycemia over 250, less than 5% of the time. Our targets for older or higher risk individuals where we allow more hyperglycemia and less hypoglycemia. Although we try to minimize hypoglycemia in all patients, really will rather than run high than low, as you all know, in these older high risk individuals. So we try to limit under 70, less than 1% of the time. And then the target range, we're more lenient, where we're not as tight control. We're just about 50% of the time or higher. We try to keep their blood sugars between 70 and 180. And we tolerate over 250, less than 10% of the time, as opposed to less than 5% of the time in a patient that is younger with potentially type 2 diabetes. All right, so here's some cases, because I think that's the best way to go through these reports and how we interpret them. And I found some cases of patients that I personally see in clinic over the past year. So case 1 is a 72-year-old man, and he was diagnosed with type 2 diabetes at 50 years old. His A1C was 9.3 when I saw him. And he has peripheral neuropathy, microalbuminuria, a diabetic ulcer. He's been a smoker, osteomyelitis, where his third toe has been amputated, and coronary artery disease. And when I saw him in clinic, I was told we really needed better blood sugar control because he had a recurrent ulcer and potential needed another amputation for osteomyelitis of another toe. He was using the Libra 3 CGM, and he takes Glargine 19 units daily, and then he uses Lispro 6 units with breakfast, 9 units with lunch, and 9 units with dinner. And then he's also on dulaglutide, empagliflozin, and metformin. So I did have time in his visit to go through a pretty detailed diet with him. And he told me he has a large bowl of Cheerios and granola for breakfast. So a really carb heavy breakfast there. He has some diet juice that he waters down. I think he called it diet because he waters down regular juice though. And then he has a snack of fruit or cheese, lunch of deli meat sandwich, fruit, baked beans. His dinner, he told me, is light, a cheese tortilla, yogurt with berries, cheese, and crackers. And he likes to have chocolate chip cookies after lunch and dinner. So here's the report from when I saw him back in October. And so the first thing I look at is his average blood sugar is 195 with a GMI of about 8. So with someone his age, that's not too bad. We're normally targeting a GMI or A1C less than around 8 without hypoglycemia. But then when you go over, oh yeah, and his variability isn't too bad. We'd like to keep it below 36 because of his age. That 38 is not too bad. But then when you go over here, his very high blood sugars are pretty high, which could affect, his healing and infection risk post amputation. So that's 25% very high blood sugars. And then his time and target range is a little lower than our goal. It's 43%. And the good thing is he's not having any low blood sugars, very minimal low blood sugars at 0% in the report. And this is the next page of the AGP report here. And so looking at this on this top graph that puts all the 14 days on top of each other with that median in the dark blue line here, you can see that overnight his blood sugars are well controlled. If anything, can sometimes range down to 70, but averaging probably around 90 on average. And then early morning, around 4 or 5 in the morning, which is when he told me he eats breakfast, his blood sugar takes a big rise up to about 250 after the Cheerios and granola and diet juice. And so up to 250. And then he remains high throughout the day. And then around 7, 8 p.m., his blood sugar starts to trend back downward. And then his daily glucose profiles, you can also see here on the summary of the 14 days that he's having high postprandial hyperglycemia with blood sugars trending down overnight. And then I also like to look at the day-to-day too, and not just the summary page. So the next step when I'm looking at the report is I do what we just did, and then I look at the day-to-day and just analyze that, and because that will show me the exact numbers, which I like to see too on a day-to-day basis. And so you can see here the significant hyperglycemia postprandially during the day, and then overnight, it looks like lowest he's going is about 72 some nights, but definitely on the lower end. So looking at this report, I'm concerned that if I increase his mealtime dose, especially with dinner, that then he's going to tank overnight and his blood sugar is going to end up in the 40s or 50s. Because right now, you can see how much he's trending down overnight. So what I'm going to do is redistribute insulin in this case. And so I'm going to take away long-acting insulin and then add more to his mealtime doses. Obviously, breakfast needs a lot more because he had some postprandial there. And then also lunch and dinner a tad bit more too. So on arrival, he was, like I said, he was on 19 and then 6, 9, and 9. So I decreased his long-acting insulin by 4 units and I changed it to 15. And then I added 3 units to breakfast because it was such a high carb heavy meal and he was having that pattern of postprandial hyperglycemia with his breakfast. So 3 units with breakfast, I added 2 units with lunch and then 1 unit with dinner. So let's see here. I took away 4 and I added 6. So he gets a total of 2 extra units of insulin because as you saw, his GMI wasn't terrible. It was around 8, but he definitely needed redistribution of insulin. So then when I saw him again for follow-up, he was doing much better. This is his profile at follow-up where you can see he's averaging now 164, where his GMI estimate is about a 7.2. His time in target is perfect. He's 63% there, still having some highs, but we really reduced the very high blood sugar with those changes where he's now at 7% instead of above, I forgot what it was, but it was too high. And then he's still not having significant lows, which is great. So he did well with those changes. And then here's case 2. This is another patient I see in clinic. She's 64 and she has type 2 diabetes, where she initially had gestational diabetes in her 30s. And she's been on insulin since she was 45 years old. She's been insulin dependent. Her A1C when I saw her was 5.8, but she'd had a bone marrow transplant from multiple myeloma. And so her A1C was just not accurate. She has mild non-proliferative retinopathy, neuropathy, and microalbuminuria. And so here's her medication list, Jardiance, and then she takes Glargine 70 units at night. And then she takes Aspart 14 units with meals. And correction factor, she uses 1 unit of insulin for every 20 that are blood sugars above 120 before meals. So she just uses the correction factor if needed before breakfast, lunch, and dinner. And she told me she was eating like 3, not a very large carb eater, 3 balanced meals per day. We didn't delve into her diet history. She was actually pretty late to her appointment that day, but 3 balanced meals per meal. And then this was her report where her GMI is 7.3. So not bad. Her coefficient of variation is about 31, so that's not too bad either. But you can see here on her time in range graph that we do not have great time in range at 59%, where we're trying to get that higher. And she's very high 7% of the time, 33% of the time, not having a lot of lows. And then this is her graph. So overnight, she is having hyperglycemia, and then blood sugar trends down around 1 p.m. to 6 p.m., and then can trend back up a little from 6 p.m. to 9 p.m. I think a big point is that looking at these graphs, we can't just determine what to do off these graphs. We have to talk to the patient and see what they're doing to get information so we can understand them better and make decisions. So with her, here's just an example of 2 of the days from Tuesday to Wednesday, what was going on. So since her blood sugar was rising overnight, oh, and I forgot to mention earlier that she'd had 2 UTIs on the Jardiance. So I stopped the Jardiance because of the UTIs. I increased her Lantus from 70 units to 76 units because of the rise in her blood sugar. So she wasn't having enough basal insulin. And then I decreased her mealtime by just 1 unit because you can see she wasn't really having that little typical rise and fall of 20. You know, we want them to have a little bit of a rise in their sugar when they eat and fall. And I was a little worried that if I went up on Lantus that she might have hypoglycemia. So I decreased her Aspart by 1 unit. So this is a situation where someone's not having enough basal insulin. And so we go up on the basal, and then I went down on the mealtime a tad bit. And I haven't seen her for follow-up. She's coming to see me soon, so hopefully she's doing okay. And then this is case 3, is a 76-year-old man with type 2 diabetes, diagnosed in 2015. And I just recently saw him in clinic about 2-3 weeks ago, and his A1C was 8.5. He's got peripheral neuropathy, microalbuminuria, coronary artery disease, and he uses Dexcom G7, and he has a C-Cure device. He's on Glargine U300, which is 2JO, 26 units daily, and then he takes Aspart 4 units with meals, which if you do 1 click on the C-Cure, it gives you 2 units. So he does 2 clicks, which gives 4 units per meals. He's also on semaglutide, metformin, and empagliflozin. He has fast food for lunch, and then he likes to snack around midnight. He stays up late. He works late shifts and then gets off and eats a snack later. Sometimes he told me. So midnight snack of ice cream or chips. And then sometimes he'll do 2 clicks for this. So if you're not familiar with the C-Cure, it's a great tool for patients who do not do well with their mealtime insulin dosing, like they forget to bring their pens with them to work, or they find it cumbersome, or they don't want to do it. So some patients who are having trouble with mealtime dosing and using their pens, they like using the C-Cure. I call it an unsophisticated insulin pump. But you fill it up to 200 units max. It uses about 20 units to prime the device, so it fills up to 180 total units that a patient can use. So they have to change it out every 4 days, but they can wear this. It's kind of, like I said, an unsophisticated Omnipod in a way, but they wear it for 4 days and then they have to change it out and they just do a click per meals. Vigo is another product similar to this, but Vigo, unlike Secure, which is only for mealtime insulin, Vigo will also constantly infuse insulin, so it will give long-acting and short-acting, and so it comes in Vigo 20, 30, and 40. So they can get 20 of long-acting, 30 of long-acting, 40 of long-acting, and then 1 click is 2 units as well, and that has to be changed out daily. So that's another option for patients that are struggling with mealtime dosing, if they don't mind wearing something attached to them. So here is his report, and his average blood sugar was 191, GMI 7.9 for his age, not too bad. The coefficient of variation is not bad at 29%, but he is having some very high blood sugars, and his time in range is not quite where we want it. And then here's the graph of his 14 days, on top of each other with the median here. He did tell me when I saw him in clinic that he's missing his Vigo dose or his Secure doses, even though it's attached to him, and trying to help with that issue of forgetting. He just gets busy at work. And so he said about 40% of the time he's not giving his mealtime dose, but he is very compliant with the long-acting dose. And then this is the 14-day summary of, how he's doing on a day-to-day basis. And you can see here the, postprandial hyperglycemia, no real significant low blood sugars, which is good. And sometimes I think he's also doing the Vigo, I think he told me after the meal. And so you can see here on like day 9 or January, whatever this is, the 9 here, that he can have a big rise and then he'll fall. And so there's some insulin mismatch going on where he might bolus afterward, or if he's eating a carb heavy meal that spikes abruptly and then doesn't have a lot of protein or fat mixed in, we can see the big spike, then the insulin kicks in and then it pulls them down where they almost become hypoglycemic. So the plan for him was, I did not change any medication doses. It's really tough, and this happens all the time, right? That patients are missing doses. It's hard as a provider to know exactly if they need more or not when they're not even giving it all the time. So I said, all right, let's keep the Seeker going. And just remember to do the clicks before meals, not after the fact, like an hour afterward. Do it before the meals. Don't forget, let's focus on this, and then we can change your medications as needed. I also advise that he should eat mixed meals because he's having some big spikes, likely from, just pure carbs that he's sometimes eating. So to make sure to eat protein and fat, and sometimes a trick we do is to tell him to eat the protein and the fat before the carb, to help reduce the big spike that patients have. And I also told him to get rid of the ice cream and chips, since that is very sugar heavy, and to just have maybe a snack. He seemed willing to want to eat an apple with peanut butter at bedtime as his snack instead of the junk food that he was eating. So it was healthier and less hyperglycemia. So that was what we did. And then I haven't seen him for follow-up because, like I said, I just saw him, but I just pulled up his CGM data after asking him to do that. And so just with those behavioral changes, he's now in range 83% of the time with no medication change, behavioral change. But now he's having some low blood sugars 2% of the time, which I don't like. And you can see here on the summary that it looks like sometimes around midnight he's having some lows. And then here is the day-to-day, and from January 18th to 19th. So looking at this, I'm probably gonna have one of our CDEs reach out to him, or I'll reach out to him, and we need to make some changes here. So I need to ask him what's going on the 13th and 14th, because you can see he's having some hypoglycemia after his meals. So I want to know, is he giving his clicks after eating again, or is he doing it beforehand? Do we need to potentially reduce his click to 1 click instead of 2 clicks? Unfortunately, we have to go in 2-unit increments because it's the click device. So we probably need to do that. And then also you can see here, sometimes his blood sugar is trending lower overnight. So I also want to reduce his 2JO to 23 from the 26 as well. So we need to make some changes, but much easier to make changes now that he's not missing anything. And I would have done him a disservice if I had, when I saw that initial report, increased his mealtime doses. So I think it's important. This is an important lesson from seeing this guy to, instruct to take the insulin and then make changes after the fact. And then I also wanted to bring up someone like this who is not always giving mealtime or missing it, or you're not sure if they're giving it after the fact or before their meal. This InPen is phenomenal. So you might have some patients on InPen, but we love the InPen in our clinic if patients are willing to use it, but it's really no different than using a typical insulin pen. You just give them cartridges for the InPen instead of a pen that's already filled with insulin. So you write the cartridges separately, but they're no more expensive than a regular insulin pen. So they're given an InPen that they can use for a year, and then they have these cartridges, and they download the app on their phone, and it can actually sync with their Dexcom G6. So the cool thing about this is it's kind of like an insulin pump without wearing a pump, and that they have their G6, and through the app, it'll show what their blood sugar is. And so you enter their carb to insulin ratio or mealtime doses, you enter their correction factor, and it will take into account what the blood sugar is and do the math for the patient. So the patient doesn't have to do the math of the correction factor or the carb to insulin ratio. But it's also nice that you can do it with someone that's not doing a carb insulin ratio. So a type 2 diabetic who has set doses. So I found this in our portal. This isn't my patient, but I pulled this up just to show you that here's a patient on the InPen, and whatever provider's seeing this patient, they have them on a low carb, medium carb, high carb schedule. So they can pick for breakfast, lunch, and dinner. And then they have entered into the InPen, okay, breakfast is from 6 to 9 in the morning. The low carbs, 9 units, the medium carbs, 12 units, the high carbs, 16 units, and same with lunch and dinner. So then all the patient has to do is just say, okay, I'm having a high carb lunch, and it'll give 16 units. And you can see they're not using that on the report here. But this is what the InPen report looks like. It will give you kind of like the Dexcom reports. You can see on the left the time and range, where unfortunately it looks like this patient is high 65% of the time. They're very high. They're only in target 10% of the time. It tells you how often they're missing the doses, but you have to be careful looking at that number there, because it will record every single time the InPen's being used for mealtime. But unless the patient goes in the app and says they're using their long-acting insulin, it won't record that. So it says here this patient's missing 20 doses, but technically I have a feeling they're probably giving their long-acting for that 14 days, and they've really missed 6 days, the 2 for breakfast, 3 for lunch, and 1 for other meal. And then also it gives you the glucose variability, how often they're using the calculator on the app to do their insulin, the average total daily dose. So this patient's using about 22, 23 units per day. And you can see here, you can do the target and the correction factor. And this patient overall is just running very high. And then the InPen report that you pull up on, it's on the Medtronic Care Link is where you pull up the InPen report. It also shows you the day-to-day blood sugar, and it will tell you when they're using the app and when they're giving their doses. So you can see here, Saturday, January 18th, they did a medium carb breakfast where they get 19.5, a medium and a large carb meal around noon. And let's see here. Yeah, so I mean, once again, this isn't my patient, so I haven't spoken with them yet, but just looking at this report and eyeballing it, we'd have to talk to them, but it looks like they need more long-acting insulin because they're constantly running high. And you can see here Friday, January 17th, when they do this medium carb breakfast, it's definitely not enough to cover whatever that medium carb breakfast is. So they probably need, that needs to be adjusted, and they need more insulin there as well. So once again, InPen's a great option for your patients if they're interested, and is a great tool for you to help them out. So who are good candidates for CGM? Any patient who's having hypoglycemia or hypoglycemia unawareness, the brittle diabetics who are type 2, who get high blood sugars, low blood sugars, patients on insulin. Obviously, any patient on insulin could benefit from this. There are current rules for when Medicare, Medicaid, TRICARE, and insurance will actually cover CGM. So the current rule for Medicare is patients need to be on 1 insulin injection per day, which is great because it used to be 3 injections like Medicaid and TRICARE. So I'm hoping that Medicaid and TRICARE will change their rules and follow Medicare and require just 1 insulin injection per day instead of 3. But as of now, Medicaid and TRICARE say patients have to be on 3 insulin projections per day for them to cover it. When they are on CGM, they need to be seen every 6 months for TRICARE, Medicaid, Medicare to keep covering the supply. So they need to, be compliant with patient visits in order for the insurance to keep the supplies going. And then commercial insurance usually varies, but it usually follows Medicare's rules. But like I mentioned, the out-of-cost price for Libra, isn't great, but isn't terrible. It's about $75, $85 a month with a GoodRx coupon. I found that patients often get it cheaper at like Costco and Target, sometimes over some other pharmacies. Unfortunately, Dexcom is more expensive out of pocket. It's usually like anywhere from 100 to 300, I've heard patients say. So a Libra is definitely the cheapest when it comes to out-of-pocket cost. I think instead of saying who are good candidates, a better question would be who are not good candidates. I definitely have some patients that don't want to know their blood sugar at all time. It makes them feel anxious. It makes them feel like their life is being dominated by their diabetes. And so if they're doing well not on it and they don't want to wear it, I would never push it on an individual where they find that the constant data overwhelms them and creates anxiety. So that would be a candidate that might not be a good candidate. I also had a patient who didn't like things attached to him. He really just didn't like the sensation of something being attached. And so that's another individual that, would not want a CGM. And then how do we integrate this into our clinic workflow? You guys might have something similar. We have a practice ID for LibraView and Dexcom Clarity. And so basically the patients just pull up their apps on their phone and then they enter our clinic ID like UC Health Endo, and then that'll automatically in the cloud send their information over to our portal. In the past, when we didn't have that, we had, they can generate a sharing code with Dexcom that then you just enter the sharing code into Dexcom and you can see the data that way as well. The really awesome thing in the pipeline here is that everyone is working on Gluco integration in Epic to provide CGM. So I've been on some of those meetings and it sounds like this is going to happen soon. This year for sure, within the next couple of months, hopefully. What we'll be able to do is in Epic, there'll be a button that we can push that'll just pull up the report through Gluco, and that will work for Dexcom. It's already been working at other institutions for Dexcom, and they're working on contracts with Libra to have Libra be pulled up too. So that's really going to help that you don't have to get two separate screens pulled up, and you'd still have to do a snip or a cut and paste of some of the info if you want to put the graph of the target in your note. But there are some dot phrases that might put averages and things and just pull it in without cut and pasting is what I heard. So super exciting. And that's going to be available to primary care clinics, endocrine clinic as well. Pretty much anyone who has Epic will be able to use that feature. And then how do we bill? The CPT code is 95251. And so we drop that into our note, and you have to show in your note that you analyzed the data and that you interpreted the CGM data. So as long as you put information that you analyzed and interpreted it, then that qualifies for the 95251. So we often put little snips in our note and just and use a smart phrase saying we analyze, interpret it, and what our plan is. This code can only be dropped by a physician or an APP. It can't be used by our diabetes educators. And you can only bill for this once per month. So, if I just looked at that other patient's CGM again within a week or two, right? And so I can't bill for that work. It's only once per month. And then you can't report it if someone's in a remote patient monitoring you can't report it with a 99091, which is a remote patient monitoring code. We often use the modifier 25. So with the modifier 25, that means we did a clinic visit and we also, had a plan in our clinic visit. And so we just put the modifier 25 in our clinic note and with the 95251 code so we can bill for that as well. All right, so in summary, CGM is an excellent tool. It helps patients, it helps providers in getting better diabetic control. I would remember that Libra CGM, even the Libra, I guess now it'd be Libra 3 Plus is the cheapest out of pocket, and it's 14-day wear. So 15-day wear, so that's the one we're usually giving if someone's getting it out of pocket. And the N pen can be very helpful, which can sync with your CGM and patients who are having who you want to know more detailed information on, when they're in giving mealtime, how much doses they're missing. If they're not a great historian about that, it can give you a good tool to figure out what's going on and them good tools to see their patterns. And then the patient's input is key in interpreting CGMs, because sometimes if you looked at the ones I showed you, I mean, you wouldn't know that the patient's eating at midnight unless you talked with them and you wonder why he's having that rise. And so talking with the patient is key. And that's it. Then this is a dog wearing a CGM, so it can be helpful in the canine and animal world as well. And thank you for having me.
Thank you, Dr. Lawler. Other questions from the group? While people are pondering those, I've got one for you, Dr. Lawler. So if I see a patient who has Medicare and they're injecting insulin once a day and they're on some oral drugs, and we decide that CGM could be worthwhile, what order are you placing in Epic to like make that happen?
To get a CGM.
And what kind of, are you documenting anything? Are you saying I'm ordering CGM today, patient takes insulin? Is that it? Is that sort of the bureaucratic bit?
The bureaucratic bit is we have these dot phrases we put in. And so we do dot CGM Medicare, dot CGM Medicaid, that Jen Madrid, who you all might have met, she's our guru diabetes educator who's been here forever. We put those in the note that just basically, like you said, yeah, it says patient is on at least 1 injection per day. They have type 2 diabetes. They need a CGM to monitor the blood sugar. We are prescribing a Dexcom G7. And so that's the phrase we kind of put in our note. And then they help out with all the paperwork. Unfortunately, with Medicare, it usually needs to go through DME as opposed to a commercial pharmacy. It's a lot easier with commercial commercial insurance, because you just send it to the pharmacy as opposed to DME. But Medicare, Medicaid, TRICARE, we usually send those through DME with that smart phrase. And then the educators and MA help us with the paperwork of getting that all signed. They're using that, what's the name of it? They send it to us electronically now through a portal to just sign, which is really nice. That I think Salwa, our endocrinologist, was working at integrating that in the geriatrics clinic. And I think she was going to target you all next to help with this paperwork of getting the CGMs covered.
And if we send a patient to a diabetes educator, can they just do all of that? Because I think that, obviously there's sort of a reluctance to get through the DME thing and hoping you get it right. And, pretty soon you're doing it wrong and it's a big time suck. And so
I agree. I mean, I had this idea a couple years ago that I talked to Jen Madrid about, and she thought it was a brilliant idea. If we could make there's probably some bigwigs on this call, like Chaco or whatever. I had this idea, instead of our endocrine clinic having our MA and our educators do it, in order to make this easier for primary carers, because I mean, it's a good billing opportunity for you. We don't need to see the type 2 non-complex patient on a CGM, but it's a great billing opportunity and you should be able to do it yourselves, right? So my idea was to have UC Health, kind of like our PAR departments, have a department that does this. So they would do our endocrine, but they would also do primary cares. And so that department would just do all the paperwork. We could all put the smart phrases, because for me, it's magical, right? Like all I do is put the smart phrase in it and I send it to our educators and then they do it. And they're doing behind the scenes, the paperwork of sending it to the DME and all that. But I think we could very easily, and if we can't combine it, you guys could have your own separate internal med person that's like our educators and our MA to do the paperwork. Because I agree, that's the biggest hiccup to having you all do it. And I feel like sometimes we're seeing patients in endocrine clinic that you guys don't really need us to see, but it's because they're on CGM and the paperwork's tough.
Yeah, absolutely. Helen, there's a few questions here in the chat. I can feed them to you. I don't know if you're able to look at them, but
Sure.
There's a question. Let's see. The first one from Dr. Foos. Do you have a resource for billing 95251? How to enter it in Epic? Evidently, he's tried it in the past and hasn't been able to figure it out.
So Brandon, I'm pretty sure that's an issue with that code not existing in our department specifically. I'm placing a request to get it added.
Okay. And then do we have a timeline for integration with Epic? I think that's the Gluco technology you described, Helen.
Yes, soon. I was just on a meeting last week about it, and Sinai is using this, and then they're really liking it. And so we're far along where they're working on doing a test pilot for us. So I can't get the exact time whenever they're gonna make it happen, but I mean, we should get the test product soon. So I would say probably within like 4 months max. We're pretty far along.
Excellent. There's a comment from Tom McKenzie at Denver Health. He says, I work at Denver Health. I'm not familiar with the AGP report. Is that a product of the CGM vendors or a custom Epic build?
Yeah, that is the CGM. So both the LibraView, which is Libra's product, and Clarity, which is Dexcom product, when you log into that portal and pull up a patient report, it provides this ambulatory glucose profile report, where it's just a way for us to see the data. And so when it's integrated in Epic, or if Denver Health gets integrated, it should just pull up that report for us to see in Epic as well. But it will be through the vendor. It's the way they display it.
Thank you. A question from John Kepi. Does it matter which pharmacy you send the CGM to, or are all pharmacies able to dispense these?
With commercial insurance, it doesn't matter. We send it to wherever the patient wants to go. Although I have found sometimes out of pocket, they get better deal at other pharmacies. So I tell them to shop around. I'll usually send it to their pharmacy they always go to make it easier. But then I tell them if it's more than $85 out of pocket, or this is for someone that's paying out of pocket, then to go elsewhere. If it's under their insurance, it should be covered in any pharmacy. But then unfortunately, like the Medicare, Medicaid, TRICARE, like those are going to whatever DME that their insurance makes us use. But I think Salwa is going to be great in helping you all potentially, because this was her QI project, was trying to get CGM integration easier for primary care clinics. And she started with geriatrics. But I think she could be huge in helping you all get that DME component down through the way that we're doing with, I'm blanking on the name, Parachute. That's what it's called, Parachute. So Parachute, we used to have to sign it differently, but now Parachute, they just sign it, they just put all the info for the DME in Parachute, and then it comes to our email, and we just click sign. And so let's say they do eight patients in one day for me. I don't even have to sign 8. As long as I sign the most recent Parachute request, it signs all the DME stuff and gets sent through our folks. And I think you all could use Parachute too for those folks that need to use DME for the supplies.
Great. That's all the questions that I'm seeing. I think, Helen, I think it'd be great to have a conversation about kind of lowering the activation energy that's required to get CGM for our patients. I just think the barriers are tremendous for us. Your point of contact is probably Rob Doolin for that.
Okay.
And then hopefully we can make these a little more accessible. So
I like that. Maybe Rob, me, and Salwa could all meet, and we could see how we can make it easier for you. I do think that it'd be a lot better if you just had a department, like you just send it to a group, right? Like send it to the DME group. That's your own, I guess. Or if we could combine in the, whatever, but we'll figure it out.
Awesome. Well, thanks for joining us this morning. Really enjoyed that talk. I appreciate your time.
Okay. Thank you.
All right. You take care.
Okay. Bye.
All right. Bye.